You have to know how your product performs. What most companies won't tell you is cost per billion platelets. I would rather equip the reader to understand is how to evaluate a good product rather than just being told what the name of the product is. So use of cellular therapy like adipose-derived injections are usually used for high-grade partial tears greater than 50%. So for low-grade tears, using PRP or PRP with protein concentrate is usually adequate, but with higher grade tears, we do use cellular therapy, both bone marrow concentrate and adipose. But if there's a gap that requires a scaffold, then we'll use adipose. So there is some studies that combining MFAT with PRP is additive or complementary. I currently don't use combination therapy to allow for a cleaner tracking on my outcomes data, but usually with higher grade stuff, higher grade injuries and pathology, I use cellular or adipose or bone marrow. And then with low grade injuries, especially for tendon, I use PRP, high dose PRP. So I would switch it around and say, the recovery time with intratendinous versus a PRP versus intratendinous adipose, I think is probably an appropriate timeline is to expect 48 to 72 hours for recovery. And I don't think adding PRP to an MFAT technique would significantly change that recovery expectation. There's no significant difference. Whether you use, it's 60 mLs of blood either way. The 160 ml, 230 mLs, 610 mLs, it's all the same. From a blood draw perspective, if I draw 120 versus 60, it's twice the platelet dose, right? But if you're asking using tube size for centrifugation, I'm not aware of a study that shows any change, whether you use 610 mLs or 160 ml. But if you're drawing more blood, then your concentration is going to be higher. The best PRP kit providers are those who allow you to highly concentrate, and for those that have a reproducible way to get a certain platelet dose, as well as an elevate, like a high greater than 80% platelet recovery percentage. So it's an efficient kit. It allows you to adequately concentrate, and you're able to be reproducible. Now, I'm sure they want me to name the top 5 kits, and I think that there's new kits coming out all the time. There's a new kit coming out in April. I haven't seen the performance data for it. That might be the best kit. There's, when there's changes to certain kits, there may be changes in the performance of kit 1A versus 1B from the same company. So as an example, Arthrex ACP is not the same product as Arthrex Angel, is not the same product as the Arthrex ACP Max. Those are 3 different products with 3 different recovery protocols, 3 different Injectate outputs. So I can't, there's 2 studies that have been done. Dr. Jeremy Magalon has a very beautiful, very comprehensive list of those data points. And then Dr. Don Buford did a recent overview of the top 5, but there's new ones. I think there's 3 new ones that I don't think have been evaluated in any of those papers. And so what I would rather equip the reader to understand is how to evaluate a good product rather than just being told what the name of the product is that's great. But there's about 5 or 6, maybe 7 high quality, high percent recovery, and high dose producing injectates. Same thing. I think if there's, a plethora of new products, I think at least you should be doing quality assurance, whether you have that on site or you have to send it off quarterly. You should be doing quality assurance measurements on what your Injectate is. What is the reproducible dose that you can produce? What is the % recovery rate, kind of across the board? No, because those PRP kits they're disposables, right? And so they buy a kit for the one patient. They've been using this style kit. It's like, buying a syringe. And okay, if a new good syringe comes on the market, great, but we have to know how to make those decisions as to whether this is a good or better than what we have. And so number one, you have to measure what you have. You have to know how your product performs, and then you can evaluate whether the new product on the market performs better than, equal to, or less than the product that you're already using. I would do quality assurance testing every quarter if you don't have a machine on site. If you have a machine on site, like I test every single one of my Injectates, I know exactly what I can expect from my Injectate for each patient every time. It's a lot of practices don't have that or don't have the ability to do that. And so there are services out there that can do where you send it off and have them evaluate how efficient and how effective your said system is. So there is quite variable. And so I think one thought process is, and what most companies won't tell you, is cost per billion platelets. So if you have a 10 billion platelet dose from a single 60 cc draw that costs $200, then that's, let's see here, $200 for 10 billion. So $20 for per billion, right? Whereas if you have a kit that costs $100, but only gives you 1 billion platelets, then it's $100 per billion. And so you would have to buy 10, and that would be $1,000 to reach that 10 billion mark instead of $200 to reach the 10 billion mark. So I think that there's a cost per billion that you have to calculate to be able to compare apples to apples. So some kits only produce a 5 billion, and some kits can produce a 10 billion dose. This 10 billion dose maybe costs $300, and this 5 billion dose costs $200. But to get to 10 billion, it would be $400, right? So still the cost per billion is, I think, a good metric to look at. No, those are actually included in my list of supplements that appear to be non-harmful to platelet production. So that was actually in my things that patients can use instead of ibuprofen, Aleve, all of those things. Those are two different questions. So for NSAIDs, and we have to be clear, there's one anti-inflammatory called meloxicam that appears to not be harmful for platelet function. So some physicians will allow their patients to take meloxicam kind of ongoing. I still am quite, I don't know, I guess I'm a little conservative. And so I ask them to be off all anti-inflammatories, like oral anti-inflammatories, for at least 1 week. For the blood thinning supplements, or even blood thinners, they have to be off of those for spine procedures per spine procedure protocols. So there's a very specific protocol for each one of those, because the risk of hematoma in the spine is so significantly more, especially even in like cellular harvesting, like bone marrow harvest and adipose. We use surgical protocols for those procedures, but a simple intra-articular injection from a blood draw for PRP, we're pretty liberal with those blood thinners, especially if you have a high risk, if you go off of them. We're liberal with use of vitamin E or fish oil for simple intra-articular injections of PRP. And then we ask that all of my patients to be off anti-inflammatories, ibuprofen, Aleve, for 4 weeks after, because we want that inflammatory cascade to normalize and resolve without outside or external influence. We want the body to have that normal, natural healing cascade. Yes, I have a whole protocol that I use both 1 month before and 1 month after. And that includes curcumin, resveratrol, fish oil, vitamin D, collagen, zinc. I think there's one more that I'm not like thinking of off the top of my head, but yeah, so that is a supplement protocol that I use both before and after. And some of it is to enhance cellular metabolism and mitochondrial metabolism. And some of that is, how we create new cells, new extracellular matrix, and enhance that cellular healing pathway after the injections. These are terrible. I don't know. Let's see here. It's so random, right? So one of my favorite ones was learning how to do construction and building with my dad, and being able to, put up walls and, use hammers and nails and screws and put drywall up and paint and do all this fun stuff as a child.